Next, I would like to invite Dr. Noufal Bashir onto the stage. Sir is a senior consultant in neurosurgery and is leading the program of endovascular neurosurgery and stroke interventions at Aster MIMS Calicut. Having been trained from All India Institute of Medical Sciences, New Delhi, he has numerous international fellowships to his credit. And Dr. Noufal is married to ophthalmology, in the sense his better half, Dr. Husna, is one of us. So with neurosurgery and ophthalmology discussions on the dinner table, Dr. Noufal is the best person to speak in an ophthalmology conference. Over to you, sir.
Thank you, Dr. Rosemary. Good afternoon, all. I thank Dr. Sujit Nayanar and Dr. Thomas for giving me this opportunity. So I will be presenting few cases to show how we manage some of the neuro-ophthalmic emergencies. This is one of the case, 26-year-old female presented with severe headache, projectile vomiting. She had photophobia and blurring of vision. On examination, she was conscious, oriented, no limb weakness. Pupil right side was dilated with RAPD. There was photophobia and right abduction restriction. On fundus examination, there was papilledema. The CSF opening pressure was 850 millimeter of CSF. All other CSF parameters were normal. Blood investigations were normal. MRI showed tortuous optic nerves bilaterally. There was also increased space in the Meckel's cave, and also there was CSF intensity around the sixth nerve in the Darollos canal. We could also see some partial empty cell loss. So with this, we made a diagnosis of idiopathic intracranial hypertension. This was an entity which was described in 1937 by Professor Dandy. The nomenclature was IAH, benign intracranial hypertension, pseudotumor cerebrae. We know it is not a benign condition, as many patients lose their vision and has chronic headaches. So for this patient had a rapid deterioration of vision. We went ahead and did a thecoperitoneal shunt. That is a shunt tube which introduced into the lumbar canal and is put into the peritoneal cavity. So it is increasingly prevalent in line with global epidemic of obesity. Only a minority of patients are at high risk of rapid visual loss. It is essential to record blood pressure to exclude malignant hypertension. MRI and CSF opening pressure clinches the diagnosis. Temporary improvement in symptoms after LP also is a useful indicator towards the diagnosis. There is diagnostic criteria. If the 4 out of these 5 are present, that is papilledema, normal neurological examination, the MRI findings, and normal CSF composition, then also elevated CSF pressure. This means the diagnosis is IAH. Even if 4 out of 5 is present also, it can be IAH. But we need to exclude these conditions: venous sinus thrombosis, anemia, obstructive sleep apnea, drug-related, especially tetracyclines, vitamin A, and oral contraceptive pills, CSF hyperproteinemia, renal failure, and endocrine diseases. So there are 4 subgroups of patients: those who rapidly lose vision at diagnosis, those whose disease resolves following the diagnosis over weeks to months, and there are some patients who are in disease remission and off treatment. So management in high risk patients with impending visual loss, some form of CSF diversion has to be done. This can be either ventriculoperitoneal shunt or thecoperitoneal shunt. If there is a delay in surgical procedure, you can put a lumbar drain while doing the CSF, while checking the CSF opening pressure. Conservative management, weight loss, and pharmacological management in terms of carbonic anhydrase inhibitors. Managing venous stenosis is also important in these patients. So patients presenting with papilledema need careful evaluation and timely investigation. This entity has to be considered in patients with papilledema. It's a diagnosis of exclusion. Next case, 60-year-old female, had a road traffic accident in 2021 August, had multiple skull base fractures, 4 months following trauma, she developed itching, redness of the right eye, progressed to involve the left eye, and it was followed by proptosis. On examination, there was thrill, chemosis, and conjunctival prolapse. Bilateral IOP was elevated. MRI done outside was suggestive of carotico-cavernous fistula. So we did a cerebral DSA which showed direct carotico-cavernous fistula with connection with drainage into bilateral superior ophthalmic vein. So this was coiled with platinum coils, and you could see at the end of the procedure there was a complete obliteration of the fistula. This was immediate post-procedure, the above pictures, and the below one is 1 week following intervention. So we have either direct or indirect fistulas. Direct fistulas are the true fistulas. Indirect fistulas most of the time resolves without any intervention. Only in few cases it needs treatment. Indication for treatment is intracranial bleed, epistaxis, disabling brew, and rapidly progressing symptoms. Endovascular treatment is the treatment of choice these days. It can be transarterial or transvenous. Next case is a 34-year-old male presented with severe acute onset headache and visual diminution. Vision was 6/18 in right eye, and left eye only PL was there. This was the field, and MRI showed a large lesion in the cellular, supracellular region compressing the optic chiasm more towards the left side. This is on other sequences you can clearly see that it is a pituitary adenoma with apoplexy. These days the treatment of choice is endoscopic resection through the transnasal transphenoid approach. You can see on just giving a nick on the dura, the altered blood along with the tumor pops out. So these patients, it is important to stabilize the patients with pituitary apoplexy, and high dose corticosteroids has to be given. Most of the time visual field and visual acuity improves if you operate within a week. The ophthalmoplegia, however, usually improves even regardless of the surgical timing. So another patient, this is 37-year-old female presented with diplopia and progressive proptosis of left eye. MRI showed a large giant cavernous ICA segment aneurysm. DSA confirmed the diagnosis. You can see a large tumor-like giant aneurysm which is measuring around 3 centimeter. And we did the endovascular treatment for this. This was done using a flow diverting stent, which is known as pipeline embolization device, and you can see immediately after that there is significant stasis in the aneurysm, and it usually closes down within a month. Giant aneurysms are aneurysms which are greater than 25 millimeter, and they are really treacherous lesions with grave prognosis. Mortality rate of 68% with 85%, 68% at 2 years and 85% at 5 years. And the traditional microsurgical approach to secure these lesions is challenging, with mortality around 20%, and recent developments in the endovascular treatment with the invention of flow diversion has reduced the morbidity and mortality. Thank you.
Thank you very much, Dr. Noufal, for the very beautiful illustrations with examples of how these neuroophthalmology emergencies are managed. That brings us to the end of this session.